It is my distinct pleasure to bring to you Dr. Hoberman, who is a orthopedic surgeon up in Katona, and he completed his undergraduate education at Emory University, where he graduated with honors. He's a graduate of the University of Connecticut School of Medicine, where he graduated with honors again. And he's a total stud in orthopedics. He did his residency at NYU Langone, and that's why he's an expert in shoulder, probably reverse total shoulder and total shoulders with the staff they have over there and cuffs. But he did his fellowship at the Nicholas Institute of Sports Medicine Athletic Trauma, and that's where I had the pleasure of working with him and meeting him. Welcome, Dr. Hoberman.
Thank you for having me. Very, very excited to be here, and it's a fun topic. So excited to get started.
It's a good one. Unfortunately, Rob could not make it tonight. Shapiro. So pitch hitting as both the executive producer and my co-host is Donis Gill. Donis, thank you for pitch hitting.
My pleasure.
Good deal. The article we chose tonight is by David Parvisky et al., and it is Risk Factors, Incidence, and Management of Re-Injury Following Repair of the shoulder rotator cuff musculature. Certainly, re-tears and re-injuries and poor outcomes exist in the world of rotator cuff repair. And we hope to gain some knowledge from Dr. Hoberman tonight on why we have these, what are the risk factors, can we make a difference? Can we make a difference with surgery? Can we even make a difference with physical therapy? How can we decrease these re-tears, if you will? But it's not always a re-tear. Sometimes it's a total loss of range of motion that causes a poor outcome. The epidemiology, the incidence of a re-injury after shoulder ranges from 15% to 21%. And there's a lot of factors that go into that. And Dr. Hoberman, maybe you can expand on that in terms of age, smoking, diabetes, and then go into, not a lot of physical therapists know about fatty infiltration, but it's a big problem in the rotator cuff repair literature.
Absolutely.
Take it over, Don.
I think looking at that statistic, 15 to 20% of these rotator cuff tears are failing. That's a huge number. And we talk about surgical outcomes, and patients are always asking us about what is the percentage of success. I mean, 20% not doing well after a rotator cuff repair, that's not a good statistic. That's not something that we're proud of. It just means that there's so much more to learn and understand. And even beyond that, it's really about treating the right patient with the right surgery or not surgery, and making sure that we're very thoughtful about which patients are getting the surgery and what type of surgery that is. So kind of jumping off of that, there are a bunch of different risk factors for repair failure. Age, unfortunately, time is of the essence. And, as we get older, our ability to heal becomes harder. And part of that's blood supply to the tendon, blood supply at the native insertion. That's really what age is about. It's about, the ability for the body to heal. And as we get older, we also tend to get a little bit sicker. So there are other comorbidities that come with getting older. Smoking. Every one of my patients, that's always a question for every single patient I'm bringing to surgery. Fortunately, we are seeing fewer and fewer smokers in today's day and age, but there's still that people are definitely smoking, and smoking has such a huge impact on the body's ability to heal anything. I mean, everything from a rotator cuff repair to simple just skin incisions. If I'm doing an Achilles tendon repair, smoking is a huge, it's a huge barrier for me to say, I don't know that surgery is the best option for you, because the ability to heal that wound in the back of your Achilles, well, that's a big issue that can lead to major issues if the repair gets infected, and that absolutely translates to rotator cuff tears and repairs as well. Diabetes, diabetes does the actual nature of the disease of diabetes and that increase in glucose and sugar, that absolutely affects your tendon quality and the body's ability to heal as well. And then fatty infiltration. So fatty infiltration is such an important topic when it comes to rotator cuff tears. We're going to talk a lot about this, throughout this talk, but essentially it really fits in the algorithm of deciding which rotator cuff tears are repairable and which are not repairable. And we will dive deep into that later on. But kind of just to foreshadow a little bit, the idea of fatty infiltration is that when you have a torn rotator cuff, you have a torn rotator cuff that goes untreated for, months, if not years, the muscle actually changes, and it doesn't just get atrophied and get weaker. It actually changes into fat, adipose tissue. And
Mm-hmm.
ways of assessing that on MRI, and we'll get further into that later on, but that's where that idea comes from.
Dr. Hoberman, when the article referred to hyperlipidemia, was that what they were actually talking about? Is fatty infiltration or no?
No, actually, they
Okay.
were talking. They had hyperlipidemia as a separate independent risk factor
Okay.
that's separate from fatty infiltration.
You want to go over the difference for me now?
Yeah, so hyperlipidemia is that's assessing the the fat, the cholesterol in your blood,
Okay.
whereas fatty infiltration is more of a process occurring inside the muscle. That I'm actually, I venture to say that I don't think there's a correlation between the two of them, but that's an interesting thought. Maybe we should look into that.
We could. Yeah. I was wondering that because I didn't really. Fang reported that he observed disorganized collagen fibers in hyperlipidemic swine, but
Yeah, of
I was like, oh well, what is he really talking about? I wasn't sure, so thank you for that clarification.
course.
Good. Let's just do a brief overview of the cuff. I think everybody on this call is familiar that what the muscles of the rotator cuff are, and but what some people, and I didn't realize when I started this profession, was that it doesn't tear in the muscle. Actually, it tears on the insertion of the rotator cuff into the bone. Can you
Yeah.
talk about that a little bit?
Yeah, that's a really good point, and something that as orthopedic surgeons and sports medicine orthopedic surgeons, the holy grail is figuring out how can we recreate the natural tendon to bone interface. So the muscle turns into tendon, the tendon attaches to bone. Um, that native insertion, the actual biology of it is very specific with a series of cells that naturally, progress from tendon into bone, tenocytes into osteocytes. And that's something that we haven't been able to recreate at, in the lab or, in vivo. So that is an important point because we're just doing the best we can with a rotator cuff repair of taking that tendon and what's left of that tendon and reattaching it to the bone, and hoping that scar tissue and other things come in and really solidify it down. But we know that they've tested the actual repair versus the native tendon, and it's not the same, progression of
Okay,
cells.
that's interesting. When someone comes to your office and they present with a rotator cuff tear, how do they usually present to you? And is it usually a trauma, an insidious onset, or what's the mechanism of injury for both your athlete, which is a different population, and also your older patient, who's your older 59-year-old golfer like myself?
Of course. It is, I usually group my rotator cuffs into, there's a million different categories that you could put rotator cuff tears in based on size and everything else. But, when I'm clinically evaluating a patient, I usually put them into two different categories. And those two categories are the traumatic rotator cuff tears and the atraumatic rotator cuff tears. So the traumatic rotator cuff tears, that's typically the athlete, so to speak. I mean, the athlete could be, yeah, it could be a tennis player, going for an overhead, serving the ball and feeling a tear in there, but it can also be the guy who's carrying some stones down his driveway and slips and
Hmm.
falls, gets his arm caught. So that's the traumatic tear. The atraumatic tear is more of slowly over time, the rotator cuff quality degenerates a little bit, it gets weaker, and then all of a sudden, they've had some pain for years, but it progresses to a point where it's enough for them to come into the doctor's office and see me. And that's usually when, that's usually how I see those patients. So that's more of the insidious onset that you're talking about.
Okay. Good. And then when they come in, when they come in and you expect and you get the history and you're like, oh, I think this patient might have a rotator cuff tear. What special tests do you go for, or do you do imaging right away, or do you go for special tests right away? Give us your sort of protocol.
Of course. So, I typically start with, when a new patient's coming in, I'll almost always get an X-ray,
Okay.
just to see. I want to see one, is there any bony pathology? Is there arthritis? So that's something that we can really evaluate well with X-rays. And then it's a physical exam and a history. And usually, if there's a traumatic event, well, that's very different history that I'm looking for than more of these insidious onsets. But in terms of physical exam, sure, there's countless rotator cuff exams, and you really have to isolate each of the four rotator cuff muscles and test them individually. So, the most commonly torn tendon is the supraspinatus. So I'm using the Job test, which is,
Mm-hmm.
in the scapula, thumb pointed down. I'm testing their strength just like that. In a complete full thickness rotator cuff there, they're not even going to be able to hold it up for you. You're not doing that exam. They can't even get it up to that shoulder height level.
Yeah.
But with a partial tear or even a small full thickness tear, they're holding it up and they're having a lot of pain and weakness as you're doing that. In terms of the infraspinatus, you're looking for an external rotation lag sign where you're bringing them out with their arm at their side and seeing, you can't really see what I'm doing here, but you're bringing out their arm and seeing if they have any counter pressure as you're doing that external rotation.
You manually put it into passive full external rotation, and then ask them to hold it there and see if it rebounds or not. Right?
And I do that in combination
Yeah.
with an active strength test. So
Okay.
it's kind of rare to see the true lag.
The
I'll see
lag sign. Right.
really big injuries, but yeah, it does happen. And then for Terry's minor, we're talking about hornblower sign. You're kind of coming up here and doing some external rotation.
Okay.
Uh, and then the last one is the subscapularis. So subscapularis is kind of in its own category of a rotator cuff. It's a slightly different rotator cuff muscle and tendon compared to the other three. It's in the front of the shoulder and it's in charge of internal rotation. So
Mm-hmm.
what I'll have the patient do is I literally say, take your hand, grab your other shoulder, and then I ask them to resist me as I try and pull their hand off. You can also do the belly press. There, you'll
Right.
know about all these different tests. It's kind of that just happens to be my favorite. So, that you're really just testing. If you understand the muscle, understand how it works, how the tendon works, and what's the vector of the force, you can kind of automatically just create a strength test for it. The one last test I'll mention is the drop arm test. So the drop arm test is, I'll elevate their arm fully overhead like this, and I'll ask them to lower it slowly in the plane of the scapula, by their side. And when they reach that point where the supraspinatus really takes over from the deltoid, their arm will just drop to the ground. And they find that that's a pretty sensitive test for rotator cuff pathology.
Good. Good. Um, One test I wanted to mention that we actually studied at NISMET was the resisted abduction test in the plane of the scapula at 30 degrees, because the
Yep.
supraspinatus at that point is put on stretch. Okay.
Hmm.
So it's stretched at that level, and we'll ask them to resist, and we'll see what their weakness is there. That gives us a little bit of clue that, hey, maybe the tear's not so severe, and possibly we can rehabilitate it. Okay. Whereas the Job test up at 90 degrees with the empty cam position, there can be co-contraction, and we as clinicians could possibly be fooled. But I use all those tests you mentioned; they're excellent, and I use them all. So
Yeah, and I would just to piggyback off that,
yeah.
absolutely can get fooled so easily in the
Oh, easy.
shoulder.
Yeah.
Somebody has biceps pathology, they're testing positive for so many of those different
Yeah.
tests. And you're like, and in my mind is saying rotator cuff. And then all of a sudden I'm like, hold off, the biceps is there, and that can mess everything up. So yeah, you got to be careful, and that's where the imaging comes in. So
Totally. And as an athlete trainer, I can't tell you the times that, I think this guy's got a rotator cuff tear, and all he or she has is a contusion of the supraspinatus, but they can't move their arm because it's so painful and that's so
yeah,
inflamed. So it's not
yeah.
easy, that's for sure. Tell us about your imaging series. So you do an X-ray. Well, then you get an MRI. Do you use ultrasound? Ultrasound's the hot topic for the fellows now out there. So, I mean, what kind of imaging do you get?
And not everyone gets an MRI on my first visit after X-ray.
Hmm.
Most people do not. Um, in my traumatic acute injury showing weakness, yeah, that's someone that I want to get an MRI because there's good data to support that in these acute tears, getting them surgically early improves their outcomes. So that's a patient where I'm saying if there's an acute injury that we can identify a specific incident where this all started and I'm sensing weakness or pain in the rotator cuff, I'll push for an MRI right away. In more of that insidious onset, over years developing shoulder pain, that's someone that I'm probably sending to physical therapy first. We're talking about cortisone shots and things like that before, for 6 weeks or so before jumping into the MRI. But I am getting an MRI. Ultrasound has been shown to be effective. It's just not readily available for me, on a day-to-day. It's a little bit time consuming. So, and the MRI can really show us the full picture, whereas getting the ultrasound is great for looking at the rotator cuff in that instant, but you can't necessarily get a good sense of the
Sure.
cartilage and other things that you want to know about when you're getting this MRI.
Hmm. And no, remember, ultrasound for everyone out there is user dependent. Okay, it's anybody can do an MRI and turn on the machine. Not anybody can do an ultrasound looking for a specific rotator cuff tear of the teres minor.
Mm-hmm.
So before we go into treatment, let's talk about classification because I was enlightened by this article. I thought I knew classifications was small, medium, large, massive tears. You had full thickness or partial thickness, and now I see this classification system called let me see, geometric classification system. Are you familiar with that? And
Yeah,
tell us,
yeah.
it's kind of new for me.
Yeah, it's a little bit new as well. There's so many different rotator
Are
cuff
there? Okay.
classifications. There's so many different types. I mean, you can rate it by, size, shape, all these different descriptive classifications as well. So I kind of just use a combination of bits and pieces from different parts of it, honestly. That's how I've always treated.
Okay. Good. The classification they talked about in this was the geometric classification of type 1, type 2, and type 3, and type 4. And
Mhm.
type 1 was cuff tears classified as having a predictable good prognosis, whereas type 2 was a longitudinal shaped tear and is repaired side to side with good prognosis. You like seeing those, right, Doc? Those.
Yeah, that's a simple problem that we have a good solution for.
What happens when you have a type 4, which is end stage degeneration? There's crab meat there, and you can't grasp anything with your suture.
That is a frustrating problem when we're in the operating room
Yeah.
and usually I like to know that we're going to see that before we go in. So
Okay.
there are some cases though where you do the whole workup and you use all the different clues and you still get in there and you tug on the rotator cuff and it doesn't want to move and it shreds on you and you're scratching your head saying, what am I going to do here? So that does still happen occasionally.
When you get in there and back in the old days when I started this whole thing in 1990, they did a mini split and they
Yeah.
opened up the shoulder and exposed the rotator cuff.
Yeah.
Now you're going through the scope. What are you seeing when you're going through the scope? I can't even imagine. Are you
Yeah.
seeing
So
the
kind of the general approach for an arthroscopy is, you have your two major compartments in the shoulder. You have the inside the glenohumeral joint within the
mm-hmm,
capsule. So that's where we start. Every scope starts inside the joint. You're looking at the articular surface, the level of
okay,
arthritis, you're looking at the labrum and the biceps tendon, and then you're looking at the undersurface of the cuff, and you're seeing this the subscap in the front, and you're seeing the supra and infra. And if you can see the teres minor, great, but you don't always see it from the view that we have. And you're looking underneath it at its insertion. So my first sign of a rotator cuff tear comes
mm-hmm,
from inside the joint, and I'm looking up at the rotator cuff kind of ceiling that exists. And if I see that there's a hole through there, well, we already know there's a rotator cuff tear.
okay,
But my next step is, after we've done all our work inside the joint, is to go into the subacromial space. So the subacromial space is above the rotator cuff and underneath the acromion. And
Hold
that
on, hold on, hold on. I'm slow. So all right. So the subacromial space is above the acromion,
now
no,
above
above
the
the cuff.
rotator cuff, above the rotator cuff,
Yeah.
below the acromion.
Yes. Yes.
You have,
Yeah.
we can feel our acromion, the bone right here. We'll go
Hmm.
right underneath it. Okay.
Yeah.
This is the space where you get like bursitis, subacromial bursitis, right? Subacromial underneath the acromion. So that's
Sure.
what we're talking about there.
And then and that's where you can see the insertion of
Yeah,
the
and
of.
that's where we do all the rotator cuff work. That's where
Okay.
we're able to go and kind of medially to and see the muscle turn into tendon. And when I'm in that space in a big rotator cuff tear, it
Hmm.
how to the best way to describe it is, you have your ball, which is this is the head of the humerus. That
Yeah.
rotator cuff should go on top of it, and you just see that it's lifted off, and you can see actually into the joint. So it's kind of the inverse of when you're in the joint, but I can see into the joint, and that's a sign, full thickness tear. We have work to do.
It's not distinct tendons that you see. It's one conjoined tendon, or
Yeah.
you can see, oh, look at that's the biceps femoris, that's the semitendinosus, that's the gracilis.
Yeah,
Not
no,
really.
not
No.
really. Yes and no. So, like I said, the subscap is a little bit separate. That's in its own kind of area. Uh,
Yes.
the subscap is separated from the supraspinatus by what we call the rotator interval, and
Hmm.
that's where the biceps tendon is, and a few other structures. But so the vast majority of these tears are involving the supraspinatus. But if it goes back far enough posteriorly, well, then you start to incorporate the infraspinatus. And while you're looking at the tendon, it's not always clear when does it actually turn into the infraspinatus. You have to kind of go a little bit further medial to see when it splits off. So I'm not routinely looking at that. I just, it's important to an extent.
What if you see an MRI, you can't see any tendon attached there, and you get in there, and holy mackerel, you're looking for it, and it's nowhere to be found. Then what? Then what do you do?
Are you saying that it's nowhere to be found, meaning that it's like fully retracted? Is that or there's no tear?
Am I feeding you good or no?
Well, yeah, you
Yeah,
feel
exactly.
okay, so perfect. So yes, so that does happen occasionally. So, the concept here that we have to kind of back up for a second is that what is the natural history of a rotator cuff tear? So we already talked briefly about how that muscle that goes unused from a full thickness tear can turn into fat.
Hmm.
But the other major thing that happens is that muscle tendon that is no longer attached over time retracts, and it starts to move closer to the center of the body away from its natural insertion on the humerus. So as that happens, the tendon and muscle becomes less elastic and less able to be pulled over to reinsert it onto the humerus. So to kind of answer your question is yes, sometimes in these chronic irreparable tears, that cuff is pulled all the way back to the level of the glenoid, the actual socket of the ball and socket joint. It's pulled back to the glenoid. And when I see that, I'm saying, oof, this is not looking good. And in those situations, we have a few different options that and different pathways that we go down. Do I say we're going to do absolutely everything we can to try and give this cuff a chance, and I'll release it from everything. I'll try and, separate it from different other structures to get rid of those adhesions and then pull it back over the humerus? Or do I say we need a different solution in this situation, and the
If
road?
you put too much stretch on a muscle and you pull it back, though, it won't be functional.
Exactly. And
So
it will just re-rupture. It will just re-rupture.
yeah,
Yeah.
so that goes into your decision making process.
Absolutely, 100%.
Yeah.
And in a lot of cases, also, in these patients where it's borderline, how much tension you're putting on it, and you're like, ugh, this is a lot of tension. Well, if that does fail, well, you need that information from that first surgery to know, okay, for the next time, we cannot just re-repair this.
Essentially, the art of medicine.
Yeah, exactly.
Um, what happens when? All right, you know what? I got three tendons torn here, and they're all retracted, and I'm in there, and I need to help this patient and get this patient functional. Is there augmentation? Do you go right to a total shoulder? Do you go to a
Yeah.
reverse shoulder? Do you go to SCR, balloon? Talk about balloon. Like,
So let's
what's your
do.
algorithm?
Yeah, exactly. So that's a great question. And let's actually back up because
Okay.
oftentimes, say the majority of the time, I'm making that decision before I get to the operating room.
Right.
And we have really good tools to assess the repairability of a rotator cuff tear. When I see a rotator cuff, if I get an MRI and the MRI report says, or I see that there's a rotator cuff tear, that's just the beginning of it. That doesn't mean that you need a rotator cuff repair. We have a whole slew of different options that we need to figure out what is the best option for that patient. And it's certainly not a one size fits all. It is a very individualized approach. And that first junction that I usually ask myself is I say, is this a repairable rotator cuff? And that word repairable or irreparable for the ones that aren't repairable is really important. It's not, we don't have a definition of like what exactly is irreparable, but we have a lot of different tools and findings on the MRI and the history that cue us into, is this going to be a repairable tendon? The big one that we already talked about, and this is where we can dive a little bit further into, is the fatty infiltration.
Mm-hmm.
There's really good data that shows that when the fatty infiltration crosses a certain threshold, and that's really about if 50% of the muscle becomes fat on the MRI, it's not going to be effective if repaired, meaning that I might be able to pull that tendon over and tack it down, but if
Mm-hmm.
that muscle is actually fat, well, then what is that muscle really going to do? Because when the brain sends the signal to the muscle and says, you got to fire, we got to raise the arm over here, well, it's not actually all muscle. It's at a high risk of failing. So fatty infiltration goes into that decision making. You hit on a great point, which is retraction.
Mm-hmm.
The retraction, which is a sign of an old chronic tear. As that retracts more and more, it's harder and harder to pull it back over. So that goes in. I measure how retracted it is, and it's a really good thing to be able to show my patients and say, listen, this is where your tendon is, and I have to figure out a way to bring it all the way back over. And when I show that to patients, it really is a good it's a good visual for why this might not be a repairable rotator cuff tear. And then the last thing is, age and the biggest, and one of the biggest ones that I almost forgot to mention was level of arthritis. We don't typically get aggressive about fixing rotator cuff tears in the setting of severe or moderate to severe arthritis because there's other issues going on there. And
Sure.
just repairing the rotator cuff isn't going to solve their shoulder issues if they have a severely arthritic shoulder. So that's some of the things that are going through my head as I'm planning and deciding, can I even try and repair this before I get to the operating room? Which is why when I get in there, yeah, it still happens where I'll be like, okay, this is not repairable. But most of the time I have a pretty good sense and I can have my plan A, B, and C, ready to
Okay.
go.
Plan B and C. You want to
Yeah.
talk about that?
Yeah, sure. So
Appreciate
let's
it.
say let's say we decided that, a simple rotator cuff tear is not going to happen in this patient. What are my options? I would say option B is to say, well, you know, maybe this is a patient where the rotator cuff doesn't look particularly degenerative. It doesn't look like the fatty infiltration has settled in, but there's a lot of other things working against them, and that's where augmentation really comes into play. And what we mean by augmentation is we actually have grafts that we can incorporate into the tendon to kind of thicken that tendon insertion and help with the healing. And the main one that we use is an acellular, so it's without cells, a dermal allograft. So it's actually a skin graft, more or less, but it's thick. It has the actual dermis layer. And we use that to augment the repair. So I do my repair in my pretty much normal fashion, but I'll add this graft that helps kind of beef up the repair and give it some more integrity as it heals.
Excellent. And does that have to come out? Do people
Oh, good
reject
question.
that? They,
No, so it doesn't. It has a very low chance of any kind of reaction, although it can happen. It does not come out. It gets fully incorporated. It's kind of the similar thought process of using an allograft for an ACL reconstruction. It's just from it doesn't have it doesn't have the cells that the body can reject or anything, and
Right.
it gets incorporated into your body.
How come people aren't putting them in all shoulders, knowing the high incidence of re-tears? I
Some
mean,
some people are. Some people are. And it's that simple. I mean, yeah, the reality of the world we live in is that it's an added cost. So
right.
we are trying to be, good stewards of,
Hmm.
cost conscious and everything like that. So it is costly. Um, and there is data that shows that not everyone needs it, but there are absolutely people, surgeons, who are putting it in every single rotator cuff.
Yeah, if I have a small tear, maybe a medium tear, go ahead, repair my rotator cuff. If I got a large or massive tear, I want a little extra, little
Yeah.
extra something, something in there, you know?
Yeah, they actually there's a well-studied calculator that we can actually use. It's called it's called the Rohi index. I gotta
Okay,
really look up what the
I'll look it up.
yeah, it's a rotator cuff healing index, Rohi. And it goes, and I can basically I basically talks about the patient's age, the tear size, the level of retraction, the fatty infiltration, and the patient's like activity level, and it creates a score. And based on that score, it tells me, the surgeon, what's the chance of healing. And when that chance of healing gets below a certain threshold, well, then I'm saying definitely want to add the allograft to it.
It's AI. You can ask Siri or Alexa, hey, should I be adding this on?
Exactly. Yeah, that's the next step.
Totally, totally. Um, and if you have a patient with arthritis, are you going right for a total shoulder? Are you doing reverse total shoulder? Do you use this new balloon procedure everybody's talking about?
Yeah,
What
so
what's
so
yours?
if they have arthritis, I'm not choosing the balloon, but
Okay.
really, if they have arthritis, the end stage there is the reverse, is the reverse shoulder arthroplasty, and that's, on the spectrum of all of our treatment options, where I have rotator cuff repair on one side, the reverse is at the far end of the others of the spectrum, and it's kind of a last resort in these situations, but it's a really good option, and it's a really good option, particularly for these patients with irreparable rotator cuff tears and arthritis. Um, it's a good option because what it essentially does, and it's important to understand kind of what is a reverse total shoulder arthroplasty doing. It's actually not, it's allowing your shoulder to function and move without relying on the rotator cuff at all. It converts the deltoid into the major stabilizer and force of your shoulder. It does that through a lot of cool biomechanics that we don't need to dive into today. Uh,
Okay.
but essentially, a lot of people ask, like, if I don't have a rotator cuff, how am I going to use my shoulder with a reverse? And the answer is that it's your deltoid, and your deltoid picks up the slack and kind of does everything.
Danny. Are you still doing SCRs?
There's really such a small, yeah, it's such a small indication for SCRs, and there's so many of these options in between the rotator cuff repair and the reverse that all have their own little niche of
Right.
in indication. So to kind of like list them all out real quick, we have SCR, the balloon, tendon transfers, which includes lat dorsi. We have the lower trap transfer. We have
Hmm.
we have pec major transfers. Um, even some newer things like tuberoplasties. There's so many
Wow.
different options. So to briefly touch on each one of them, then we can dive in where we want. Let's start with the balloon. Okay, because you were asking about that before. So
Yeah.
the balloon is a cool piece of technology, and it does have a role. The balloon, the way I like to teach my patients about the balloon is that when you don't have a rotator cuff or a functioning rotator cuff, the ball of the ball and sock, the humerus, tends to escape superiorly. It tends to go up because you don't have the rotator cuff there keeping it down. So the idea behind the balloon is, well, if we can just keep the humerus in place, well, then we can get a little bit more normal function. So what we do is we actually take a deflated balloon, we insert it into the subacromial space. So now this is
Hmm.
where it's important to really understand underneath the acromion above the rotator cuff, although they don't really have a rotator cuff. Um,
Right.
and we inflate that balloon with saline. Like it is as simple as that. It looks like you're inflating almost like a whoopee cushion above the humerus. And what that does is it keeps the humerus down where it wants to live. Now, the big knock against the balloon is that this is a biodegradable um, implant where 2 years later, that's degraded. So, the next question that everyone asks is, so then what happens after 2 years? And the answer is that some people do really well and that lasts for a couple, they get the pain relief and the symptomatic relief for a few years, and other people, they don't. And that's a realistic expectation that they need to understand. It introduces another concept, not to get too deep into this, and that's the idea of a compensated shoulder. And to back up again,
Hmm.
we have people who walk around every day with full thickness, huge rotator cuff tears, and they are somehow doing fine. And it's something that we don't fully understand. But, an interesting and kind of not well understood topic is this idea that some people just have a compensated shoulder where they've learned or they've developed the ability to function without the rotator cuff. But at some point they may fall and that may become decompensated. So one of the goals of the balloon is to turn someone who is decompensated into a compensated shoulder so that way they can then function. It's a little bit of of an abstract concept there, but I've definitely seen it, and but the balloon is not for everyone.
As a physical therapist, do you change your rehab guidelines if you put in a balloon?
Yeah, yeah, definitely. You're not waiting for a repair to integrate. So I'm moving them a little bit faster.
Same thing with the SCRs too.
Yeah, same thing.
Okay,
Yeah.
good.
And that good segue, SCRs, who is that good for? I'm looking at SCRs for a patient without arthritis who's also similar concept to the balloon, where the SCR, when it's a superior capsular reconstruction, we're
Hmm.
trying to keep that humerus from sliding up. So we put something on top of it to keep it down. It's a very similar thought process as the balloon. It's a little bit more of a tedious surgery. Surgeons don't particularly love it because it's a lot of
Hmm.
little sutures, putting things in place. It takes a little bit longer, but it has a role, and that role is really in that person who's probably in their 40s, irreparable rotator cuff tear, a little bit more active. That's someone who I'm considering that.
Okay. Um, let's stop right now before we go into the rehabilitation, a little bit of the article. Donis, are there any questions from the audience? And do you have any questions, Donis?
There's nothing really from the audience yet, but the questions that I have are really leaning more into the rehab side. So I can either ask them now and transition in, or
Um, yeah, I mean, this is this is whatever we want to do with it. So,
yeah. So usually the questions that I have around rotator cuff, it's really more about communication, because I remember being a green clinician and seeing rotator cuff, and as we went over, rotator cuff is a whole system, but for the most part, most of the cases are supraspinatus based. So uh, that's one of the things that I struggled, because when the rotator cuff came in, people just said, "Oh, this is a rotator cuff." Are there any differentiations that you would have in terms of like somebody with like a typical supraspinatus or something like a subscap? Because that's some of the stuff that I wish I knew early on to know difference.
Yeah. Definitely. There's absolutely, yeah, there's absolutely differences. I would say that the first distinction is even just the size of the repair. In these huge, massive rotator cuff tears that we repair, I'm a little bit more conservative and I'm a little bit slower to get them to do their active motion. So I may hold off until like 4, maybe even 6 weeks, really. And I have no problem waiting and even risking that stiffness in order to make sure that the repair heals. But to answer your question, absolutely, the subscap versus a supraspinatus tear should be treated a little bit differently. And the main difference is is again thinking about the role of these tendons. And I did a subscap repair last week, and I saw him today, and I'm counseling him, and I'm saying I do not want any external rotation really past that, like, definitely not past 30 degrees, but even neutral, because I don't want to stress that repair and risk rupture in these first few weeks as we're getting started on the passive range of motion. So while yes, I do also limit my external rotation in my supraspinatus repairs, I'm much more focused on that in my subscap.
Are you doing a double row or single row repair with your supraspinatus? Because Park et al. Showed that if you push external rotation early, you'll cause a peel back mechanism, and your repair may fail.
Yeah, I routinely try and do a double row repair.
Okay.
I routinely try. The data on single versus double row, which is a little bit into the weeds of things, but essentially has shown patient-reported outcomes. How patients feel doesn't differ between the two, but in patients who do fail, they're more likely to have a single row, if that makes sense. It's a little bit of a nuanced understanding of the studies, but people are absolutely doing both, and I'll do both. It depends on the patient. It depends on the repair and what I see in there.
Okay.
I got another question if you
Yeah. No, keep going.
so kind of along the same lines of the different types of cuff tears. The other side is we just heard you talk about all the different comorbidities or like stages of the rotator cuff degeneration. How do you typically communicate that coming out of a surgical case? Because in someone that came from like a retracted or like heavy fatty infiltrate versus like your regular standard repair, how do you handle that post surgery?
Yeah, how do I handle it? Is the question more about like what do I tell the patient about it, and what so that way they understand?
But
Or
even with the rehab staff, because when somebody comes in with a repair like that,
yeah,
again, we get stuck with like rotator cuff tear. What is it? How aggressive can I be? How
yeah.
conservative do I need to be because this wasn't really a great tissue quality there?
I would say that probably 90% of, maybe 85% of the repairs that I do fall into that more general category, which is the ones that you guys are kind of used to seeing. And then there's probably 15% that have an extra kind of unusual component, whether it's a particularly tenuous repair or it's a particularly, bigger or whatever the case is. And in those situations, usually it really just involves that initial period of progression to active range of motion, and I will delay active range of motion a little bit.
Awesome. Thank you.
That's good, because this article, if you go to page 4 of the article, they talk about tear size down 1, 2, 3, 4, 5, 6, 7. They talk about the importance of early intervention and targeted rehabilitation. I think that was a take home message for me when I read this article. I think it's important to remember, just like Donna says, if you can tell me anything, doc, on your prescription, it's not fatty infiltration. It's not if it was a crescent or an L-shaped tear. It's what was the tissue quality when you repaired it? Was it crab meat or was it steak? And how many tendons were involved?
Yeah.
You tell me that. I think most of our therapists at our company certainly can handle any of your rotator cuff repairs. That's for sure. Is there anything you wanted to bring out that you really took home from this article, Dr. Hoberman?
Let's see. I already even stressed it in my first opening statement kind of thing,
Yeah.
but it was just rotator cuff repairs. One thing they go into in this article, which I think is really interesting, is that we haven't gotten much better at rotator cuff repairs.
Mm-hmm.
So crazy and wild to me when we've made all these advancements, and yet some of the data looks pretty comparable to the early 90s when we were doing these open. And I think that is just
Yeah.
such a wild perspective given where we are in 2025 with advancements and how we do this differently. And I will say, that we're comparing a little bit of apples to oranges in the sense that they were trying to repair everything or anything back then, maybe, and now we're a little bit more, we're a little
Well,
more targeted. But I think that's such an interesting takeaway.
yeah, as you know, when you're a fellow, it's very difficult to design a study when looking at rotator cuff repairs because we have so many confounding variables in terms of
So
number of
many.
tendons, thickness, And if you go into the study, this article, they talk about on page. Let me go to it here. The rate of re-tear was 7.2% in 693 patients, but there were lots of different rotator cuff tears, types, and sizes, and repair types. So
Exactly.
not every
Yeah.
repair is the same too. Some people do single row, some people do double row. There's a
Yeah.
lot of confounding variables when doing designing a rotator cuff study.
Absolutely.
I think that as a physical therapist, Jimmy Andrews taught me one really important thing throughout my practice, and that's you don't want to stress the rotator cuff tear too early to damage the repair, protect the repair. So he always had us start in the plane of the scapula, all right? Because in the plane of the scapula, the rotator cuff, the supraspinatus, needs to work left because you have bony congruence of the humeral head on the glenoid fossa in order for the supraspinatus to pivot off of. If you're in the frontal plane, you don't have that congruence, and you have the capsule that's wound. So you have to overcome the resistance of the capsule too.
Yeah.
So there's advantages to working early in the plane of the scapula. So that was something that I took home from James Andrews back in the day.
There's
Yeah.
another question that came in
Yeah.
from the crowd. Brandon asked, there are a number of second look studies that show that there can be quite high level re-tears. Given that early in the rehab, it's primarily mechanical fixation, do you think in general we load the cuff too soon before we really have significant biologic fixation?
I would say my answer is the answer I would say is I don't think that we're loading it too
I
soon
don't think so.
because we have a lot of studies that have actually compared early versus late mobilization, and
Hmm.
it hasn't shown a big difference in the outcomes.
I happen to totally agree with you. I think that the just like the ACL, the rotator cuff needs stress in order for it to heal too.
Yeah, I agree.
We got to put some sort of stress upon it.
And it goes against our nature. Obviously, we want to say protect, protect, protect. Like let's let this heal. But it's something that I've had to change my mindset and say, no, we have to use it as well. You have to use it in order for it to get proper healing.
All right.
Stress it appropriately. So
Yes.
don't over stress it is really the key there.
Hmm. I have one last question for you, Dr. Hoberman.
Mhm.
The role the role of corticoid steroid injections in your rotator cuff pain patient that comes in prior to surgery,
Yeah.
and will you give it after surgery? Some doctors out there do. What is your opinion, and what is your protocol?
So my protocol for before, so when if I have a new patient with a rotator cuff tear and we have discussed non-operative and operative management and we've decided that we are going to pursue non-operative management. If I've
Hmm.
decided that we're going the surgery route, we're not doing cortisone injection.
Right.
But if we decide that we're doing non-operative for whatever that reason might be, I am willing to try a cortisone injection. I like to say it's a one and done situation. I like to say we get one chance at the cortisone working, and if that fails, then we really have to consider the surgery. In real life, that doesn't really apply. If somebody doesn't want surgery, we don't make them have surgery. You know what I mean? So
Right.
if they get a cortisone shot and they say, I 6 months later, they're like, it helped me for a little bit. I need to just get past my son's wedding, in 2 weeks. I'm gonna say, yeah, I'll give you a second cortisone shot. But really, if it didn't work that first time to kind of do the trick, it's probably not going to work the second time. Then in terms of post-op, I don't entertain cortisone injections in the first 6 months. I don't really see them having a use. If I'm doing a cortisone shot post-operatively, it would probably be if I see that they're getting a frozen shoulder, or if I'm starting to get concerned about a re-tear, I'm probably getting imaging first.
Okay.
I have another question. Going back to like the fatty infiltrate situation, is that at all reversible, or is that kind of like a death sentence?
It is irreversible.
As far as we know right now, it is irreversible.
Yeah.
Yeah.
Yeah, I kind of did a little bit of a rabbit hole deep dive in that, and there was some stuff about like using some biologics to help to kind of slowly get it back, but there wasn't really confirmed.
Yeah, it is irreversible, unfortunately, and that's why getting to these in a timely manner is really important. And it's sometimes hard to convince those compensated patients and be like, listen, you gotta deal with this now, because in a year from now, it may not be repairable.
Right. Well, unless there's any other questions, Donis, that's all I had. And I don't want to keep Dr. Hoberman any longer because that was an excellent 15 minutes of discussion on re-tears of the rotator cuff. Thank you so much, Doctor, for for participating tonight. And if anybody needs a rotator cuff repair, head to Cantona. You can see Dr. Hoberman.
Exactly. Thank you so much for having me. This was great.
Thanks, Doc. Appreciate it.
Take care, everyone.
All right. Bye-bye.